in charge of this class, Justine, about those recordings, and I don't know how to access them. She said it's just to make sure, in case there's any sort of dispute or something, that but that I can't share the recordings. She actually told me not to record lectures at all. So, Toby, this recording is for you, but I'm not supposed to be doing this, so don't tell anybody, okay? All right. So, Eva, we are now recording. I'm minimizing the video, so you're not going to be recorded on this. Don't worry. Okay. Okay, great. All right, so let's see here. We are going to continue here with ulcerative colitis. We had started talking about our inflammatory bowel diseases by talking about Crohn's colitis. And we talked about the cobblestoning, how we always see involvement of that terminal ileum spot, and how we have the full thickness inflammation of the wall. That's a really important part of Crohn's colitis, is instead of just having the mucosa and submucosa involved, here we are seeing the complete wall, transmural inflammation. The other big thing on Crohn's colitis is seeing these strictures. So you can see here in the transverse colon what we refer to as a stricture. If we gave our patient a little bit of gastrografin dye to drink, and then we took an x-ray, what we would see on the x-ray is something called a string sign, where as the dye passes through this tightened lumen, it comes out on the other side very thin, looking like a string. Okay, so that's how we get our string sign in Crohn's colitis. All right, so that's just a quick review of Crohn's. Let's talk about UC. So with ulcerative colitis, we have mucosal and submucosal ulcers. Okay, so this is just involving those first two layers of the colonic epithelium. It begins in the rectum, so it begins all the way in the rectum. That's where it starts, and it can extend proximally up to the cecum. Okay, so this is a continuous involvement. The remainder of the GI tract is unaffected. So when we talked about Crohn's disease, we said that one of the things that help us identify that it's Crohn's disease is we may see ulcers around the lips. We may see inflammation of that terminal ileum or other places in the GI tract. With ulcerative colitis, we just see from the rectum all the way to the cecum. It's just involving the colon, okay? And it's going to be a continuous inflammation. Patients typically present with left lower quadrant pain, which refers to about the area of the rectum or sigmoid colon, with bloody diarrhea, okay? In terms of how our patients present, this is very important. What I want you to remember is that patients with ulcerative colitis tend to present with copious bloody diarrhea, a lot of bloody diarrhea, okay? That is a typical presentation for ulcerative colitis. With Crohn's disease, typically your patients are first going to present with watery diarrhea, okay? Remember, the inflammation is not concentrated in that rectal area. So first, the diarrhea is just going to be indicative of maybe some sort of inflammation, right? If you see a patient that presents with a lot of watery diarrhea, probably the first thing that comes to mind is some sort of infectious colitis, right? A viral infection of the colon or a bacterial infection of the colon. That's the first thing that comes to mind when you have a patient presenting with a low fever and lots of watery diarrhea. The way that we decide that it's not infectious colitis, that is actually Crohn's disease, is we do a colonoscopy, and we see that cobblestoning and the skip lesions and what have you, okay? So that is why I want you to remember with ulcerative colitis, we typically see bloody diarrhea. With Crohn's disease, it typically starts with watery that may progress to bloody diarrhea as the inflammation becomes more severe. And that's not something that's totally logical or obvious, right? Because you think with Crohn's disease, you have a transmural inflammation. We're affecting all walls of the colon, and so that one should be more bloody than something where we're just affecting this mucosa and submucosa. All right, so don't get it confused. Here, even though it's just mucosa and submucosa, we do present with bloody diarrhea. Okay, great. So if we took a little biopsy, what we would see is a crypt abscess with neutrophils. What a crypt abscess is if we look at the histology of the colon, what we see is we have areas of epithelium that protrude outwards, okay, and this is full of epithelial cells. This is going to make our bicarbonate and potassium and excrete it out into the GI tract. And then we have these areas called crypts. Okay, and in crypts we have a lot of immune cells. So our white blood cells, macrophages, B cells, those are all going to be located here in the crypts. So when we have ulcerative colitis and we have this autoimmune attack of our colon, what happens is we actually start forming abscesses down here in these crypts. Okay, so this would be a crypt abscess. It's in between these epithelial protrusions, and it's really just down here in what we refer to as the crypt. Here we'll see a lot of neutrophils, okay? This is an inflammatory state, so we're going to see a lot of neutrophils in these abscesses. Pseudopolyps, where we have a lot of inflammation. So if we look at this ulcerative colon in this middle image, you can see that you have the entire lumen is involved, the entire wall is involved. If we look at the second picture, you can see that there's small areas like here that are not involved. Small area here, not involved. Small area here, not involved. This is a pseudopolyp. When we look at this on a colonoscopy, we may say, oh, this patient has a polyp. But this is not actually a polyp. This is not actually a protrusion of epithelium. What this is everything else around it has been destroyed by this inflammatory state. So you have everything else that's been destroyed, and we just have this little bit of healthy tissue left that kind of looks like a polyp. So it's not a true polyp, it's a pseudo polyp, because all that it is the remainder of healthy tissue there. Loss of haustra, and we can see here on our healthy colon, we have these outpouchings in the wall of the colon. This is normal. This is called our haustra. Okay, and these are the parts of the colon that are going to squeeze tight to sort of move our fecal material forward. When we have inflammation, we lose that haustra. And you can see here in our ulcerative colon how it's completely smooth, the wall of the colon. And so this leads to a lead pipe sign on imaging. Okay, and why is that lead pipe sign? Normally when we image the colon, we can see the haustra. This is our transverse colon, this is our descending colon, ascending colon. So we can see these nice haustra, right? When we image our colon. When we give our patients some gastrografin, they swallow it, it shines really nicely. When we have ulcerative colitis, we're going to have areas of our colon where we can't see any haustra. All right, so here's our transverse going into our descending colon, and you can see that there's none of these nice pouchings. All right, it's completely smooth, giving us that lead pipe sign. Complications of ulcerative colitis: toxic megacolon, carcinoma. The risk for carcinoma is based on how much colon is involved and the duration of the disease. Typically, we don't start screening for it until the patient has had the disease for about 10 years. Okay, this is kind of getting into more step 2 type material. When do you start screening for ulcerative colitis? But I just want you to know that the risk of cancer is a lot greater in ulcerative colitis compared to Crohn's disease. The other very specific disease that these patients get is something called primary sclerosing cholangitis. This is what I was trying to think of the other day, Eva, and I couldn't think of the name. So primary sclerosing cholangitis is a disease that affects our bile system, right? Our cholangeal system. And what we get is sclerosing of the bile ductules, and which prevents bile from moving forward and getting into our gallbladder, entering the GI tract, okay? The only condition where you see primary sclerosing cholangitis is ulcerative colitis, okay? These two are associated with one another. PSC is associated with UC. Okay? PSC is associated with UC. Okay? And just sort of a random thing here, smoking is going to be protective against ulcerative colitis. Cholangioesclerosante primaria. Oh my goodness, I just killed that. Cholangitis esclerosante primaria en español. Okay, very good, Eva. Thank you for that. I did not know the name of that one, so that's helpful, thank you. Let's see, anything else we can say about ulcerative colitis? Do you have any questions on ulcerative colitis before we move forward?
No, I'm okay.
Okay, great. Okay, so just showing us the inflammation going from the rectum and progressing proximally in ulcerative colitis, and then seeing these patches in Crohn's colitis, okay? And with the terminal ileum being a spot we're really worried about, because the terminal ileum is where we absorb what vitamin? B12, good. B12, and also, not a vitamin, but the other thing we absorb here is going to be our bile. Okay, we're going to absorb those bile acids, recycle them, so we always have a nice supply. Okay. So diverticulosis, here we have pathologic outpouchings of mucosa and submucosa through the muscularis propria. We're only going to have outpouching of these two layers, so it is not a true diverticula, right? Because it only has two layers. This is related to wall stress, so constipation, straining, low fiber diets, and risk increase with age. I think all people, once you reach a certain age, will end up having some diverticula in their colon. One thing I want you to keep in mind, that diverticulosis, where you have diverticula, is not the same thing as diverticulitis, where you have an infection of one of those diverticula. Okay, different, right? So diverticulosis is just an outpouching. Diverticulitis is when one of those diverticulosi get infected. Okay, diverticulosi. I think diverticula is the word, but anyway. So these arise where the vasa recta transverse the muscularis propria. There's a weak point of the colonic wall, just sort of a trivia type question that they may ask you about, but that's sort of the weak point on the wall. So here's sort of a transection of the wall of our GI tract, right? And so the point at which an artery enters, and then so that it can go through the wall, it has to enter at some point, right? And so wherever that artery enters is going to end up producing a weak point. And then so that where that artery enters is going to be where the diverticula forms. This would be our diverticula. Okay. Typically, these patients are going to be asymptomatic. However, diverticulosis is the most common cause of lower GI bleeding, right? We're pouching out right where the artery enters, and so there's a good chance that that artery can cause a small bleed. Okay, this is not going to be copious amounts of blood per rectum. This should just be a small amount of blood. Maybe when your patient uses toilet paper to wipe, they see a little bit of blood on the toilet paper, that could be a sign that they're having diverticulosis, right? Could be a sign of colon cancer. It could be a sign of hemorrhoids. Could be a sign of a lot of different things. But in terms of the most common cause of having that little bit of blood, it would be diverticulosis. Okay. Diverticulitis, this is going to be due to obstructing fecal material. So here, a little bit of fecal material gets inside of a diverticula, and it ends up staying in there. And so, in the colon, we have tons of anaerobic bacteria. So if this gets closed off, this little diverticula gets closed off, that anaerobic bacteria is going to be able to flourish and cause, a lot of pain, inflammation, and fulminant infection at that point. Typically, your patient is going to present with appendicitis-like symptoms on the left lower quadrant. So when we say appendicitis, we're all very comfortable with what appendicitis looks like. Periumbilical pain that progresses to become right lower quadrant pain, this point tenderness at that location, so on and so forth for appendicitis. With diverticulitis, the most common place to get diverticulitis, if I can draw the colon here. So here's our rectum, here's our sigmoid colon, here's our descending colon. The most common area to get diverticulitis is going to be right here in our sigmoid. Okay, and so you have all this pressure building as your patient is straining, trying to poo. All that pressure is going to be transmitted here into the wall of the sigmoid colon, and so this is where you're going to have most of your diverticula. Okay, so when we say that the most common presentation for this is appendicitis-like symptoms on the left lower quadrant. Why in the left lower quadrant? Because that's where most of the diverticula are. So that's the most likely place for this patient to develop diverticulitis, right? Okay, so this patient is going to have pain on palpation, tentative palpation on that left lower quadrant, should have an elevated white blood cell count, low fever, and then when you do a CT scan, you'll probably see a ton of these diverticula and sort of arrive at your diagnosis. You can have progression to fistula if you have an inflamed diverticula that ruptures and attaches to a local structure. A colovesicular fistula presents with air or stool and urine. So here we have a fistula between the colon and the bladder. Okay, and so typically the way that they're going to describe this is they're going to say that this patient has very bubbly urine. When they pee, they see a lot of bubbles inside. The other thing that they see is the urine is going to stink. Okay, very stinky, bubbly urine. I want you to start thinking about a colovesicular fistula. Okay, do not miss this on a question because there's not a lot of stuff that causes that, right? When you have something like nephrotic syndrome, when we talk about nephrotic syndrome, sometimes they describe it as frothy urine, but when they're saying that it's bubbly with a very bad smell, that is going to be your colovesicular fistula. Okay, I want you to think about that, number one. Okay. All right, so that's some of the complications we can see with diverticulosis. Ischemic bowel disease. This is really just as it's described is what it is. We have a vascular compromise, meaning we have some sort of discontinuation in blood supply to any major branch of the celiac, SMA, or IMA, causing acute intestinal ischemia, right? We have part of our intestines that is dying due to loss of blood supply, okay? Loss of blood supply is going to ultimately cause a transmural ischemic necrosis of the bowel, dead bowel, okay? And so how do these patients present? It's a very, very specific way they're going to describe these patients, okay? Abrupt abdominal pain associated with meals. Abrupt abdominal pain associated with meals. Why? When you eat, you have a higher demand for oxygen and blood supply to your GI tract. Okay, so our patient starts eating, and about 10 minutes into eating, they start having really severe pain in their abdomen, in their abdominal area. We should start thinking about ischemic bowel disease. And what's happening here is if this is our SMA, so our SMA, we get our right colic, our middle colic. Our right colic goes here to the ascending colon, and say we have some sort of plaque here, right? Some sort of atherosclerotic plaque. Now when the colon starts having a higher demand for blood supply, we aren't able to supply that blood, and so we're going to end up getting essentially what looks like angina of the GI tract, right? Angina is due to loss of blood supply to the heart. Here we have in the GI tract abrupt pain associated with meals, okay? And so, you know, when we talk about pain with meals, a lot of times the first thing that we jump to is, okay, this person has a peptic ulcer, right? That's sort of the first thing we think of. Oh, pain with meals, okay, peptic ulcer, GERD, something along those lines. Keep this on your differential, ischemic bowel disease, especially if they give you a patient with a history of coronary artery disease, peripheral vascular disease, hyperlipidemia. All of these conditions increase your risk of ischemic bowel disease, and so we should definitely sort of have we should be really focused in on what our possible diagnosis can be in that case. Because we have dead bowel here, we may see some bloody diarrhea, vomiting. If we do not treat this, if we have dead bowel, we're going to have dead patient. This is a very dangerous diagnosis, and so we definitely need to take this patient to the operating room, open up their abdomen, and take out any dead bowel there. We said that occlusion of major blood vessels typically comes from atherosclerosis. Any patient with hypercoagulability, aortic aneurysm, a volvulus where the part of the GI tract wraps around itself, we talked about before, or shock hypotension. So you can have a small intestinal ischemia where it's due to the SMA obstruction. The blood supply is most vulnerable to interruption at or near the source. So this can be pancreatitis, tumor, lymphadenopathy, atherosclerosis, thrombus, embolus, a lot of different causes here. They're all going to kind of present in the same way. Colonic ischemia could be from the SMA if we're talking up to that splenic flexure, which is our what? Watershed area right there at the splenic flexure. And then it could be an IMA if it's due to anywhere from the splenic flexure to the sigmoid. Okay, and again, that splenic flexure area is the most vulnerable to ischemic bowel disease. Mucosa is going to be most susceptible to ischemic injury. Musculature least susceptible. Why? Well, if we think about the wall of our bowel, we're going to transect it here. Okay, so the artery is going to start on the outside, and it's going to send penetrating branches to the inside. okay, and it's also going to send a branch all the way around. And these branches that go all the way around are also going to be sending penetrating branches. So if we start to lose the volume of blood, what's going to happen is the most inside areas are going to be affected first by ischemia. Then will affect the submucosa. Then the muscularis will be one of the last layers that will be affected. Okay, so first is going to be the mucosa that's affected. Last would be the muscle. Okay. Chronic ischemia is going to lead to a withering atrophy of the surface epithelium that may progress to ulceration, but the submucosa and muscularis propria are spared. And so this is like in our patients with shock. We mentioned before with our acute gastritis that we put patients in shock on a PPI to prevent their the mucosa from becoming inflamed and forming a gastritis. It's the same idea here. When we have that chronic ischemia, eventually all of the mucosa is going to sort of die off because it's not getting enough blood supply or nutrients that it needs. Okay, so we end up seeing some ulceration at surface epithelium, but the submucosa, muscularis propria would be spared. Angiodysplasia, this is the second most common cause of lower GI bleed. What is it? Essentially, it's just a bunch of vessels located in the cecum of right colon that sort of start to grow out of control. Okay, so we have the wall of our colon. Okay, and so that's left colon. Here's our right colon. We have the wall here, and then there's just like one focus where, for whatever reason, a bunch of growth factors get released in this area, and we get a bunch of vessels growing. Okay, so angio meaning vessels, dysplasia meaning kind of growing where they shouldn't be growing. And so this little growth of vessels can bleed into the GI tract, leading to anemia and leading to seeing blood in the stool. Okay, the incidence for this condition is going to increase with age, and it's just another thing that can cause you to have hematochezia or blood in the stool. Hemorrhoids, swelling of internal or external perianal tissue due to persistently elevated venous pressure, and can be straining at defecation, pregnancy, your portal hypertension leading to those varices, your Peru, right? I learned this from a really smart student I had one time. Sedentary lifestyle of prolonged sitting. Okay, so hemorrhoids are actually very normal, and they're actually something that are physiological that help us stooling. So our internal hemorrhoids, we have distensible veins on the upper part of our rectum, so that as stool slides out, I know this is a disgusting topic, but just so you know, as stool slides out, those veins actually become engorged and sort of allow the stool to sort of smoothly move out of the rectum and anus. And so these internal hemorrhoids are actually very normal to have, and everyone has them. However, once they start to swell, they get larger, we get older, they can start to bleed and cause problems. We have internal hemorrhoids and external hemorrhoids. Which ones are the painful ones, Eva?
I'm not sure. Internal?
So, with internal hemorrhoids are actually not going to be painful. With internal hemorrhoids, we just have a swelling of the vessels, and the tissue on the inside of the colon. Just imagine you had a large meal, and then you have a small amount of that food inside of your right colon, around the cecum. Okay, you probably had a breakfast, you have a meal, you probably have something in your colon right now. Can you feel that? Can you detect that? Can you say, oh yeah, I feel a little bit of food right there about my cecum? Not really, right?
No.
Not really. That would be a weird sensation. So here we get to talk about sort of our differentiation between our somatic sensation and our parasympathetic, sympathetic sensations. So our sympathetic system is able to detect if we have something in our GI tract, right? We have this system dedicated to that. But our sensate system, the system that allows us to touch and feel and have sensations, is not active inside of our GI tract. However, inside the rectum, we have one point, and this is called the dentate line because it kind of moves up and down like teeth. And this is going to be our differentiation between our sensate area, where we can have sensations and feel, and our insensate area, where the parasympathetic, sympathetic nervous system is going to be responsible for detecting any changes. Okay, so above the dentate line, we cannot feel what's there. At least not in the way that we can say, feel what's in our mouth, or feel something brushing against our cheek. We can't feel anything in that way. However, below the dentate line is where we start to have real sensations, and we can feel something there. And so, when it comes to our internal and external hemorrhoids, our internal hemorrhoids are going to be emerging from above the dentate line. And so when we have these hemorrhoids that are becoming distended, these are not going to be painful. Okay? Why? Because we don't have the nerves there to detect pain in the same way that we have other parts of our body. Below the dentate line is essentially skin. Okay? And this skin is going to be innervated. And so if we have a protrusion of these vessels below the dentate line, this would be painful. Okay? And I'm just going to write the name of the line, dentate. Okay? Dentate line. Okay? And that sort of differentiates our internal and external. That's how we decide, is it an internal hemorrhoid or an external hemorrhoid? We look at the dentate line. The second thing we look at is it painful or not? And external hemorrhoids tend to be painful. Internal hemorrhoids, they can get quite big, but they don't become painful. Okay? Great. Colonic polyps, so moving kind of into a talk about cancer at this point. We're going to be making that transition. So colonic polyps are just a growth of tissue within the colon. They can be neoplastic. They can be non-neoplastic, totally benign. We need to characterize them in terms of how they look, or at least gastroenterologists do. The characterizations are flat, sessile, or pedunculated. Okay, and this is going to be on the basis of protrusion into the colonic lumen. So when we have a flat polyp would just sort of be against the wall like this. A sessile polyp is going to have some indurations and some changes in the depths. And a pedunculated polyp will be an outright polyp that we're used to seeing. I think when most people think polyp, they think of the pedunculated polyp, but we also have flat and sessile versions. Okay. If we see a polyp, even just seeing a flat polyp like this, we are going to take a biopsy and look at what the histology looks like. We're trying to rule out cancer whenever we see a polyp after all, so we need to be able to take a biopsy and look at the histology. A hyperplastic polyp is non-neoplastic. It's just a growth of extra tissue. So think about our pedunculated polyps. This is just a bunch of extra endothelium, epithelium from the wall of the colon. Okay, it's non-neoplastic. There's no risk for cancer here. Okay, relatively common. Hamartomatous, usually non-neoplastic. The way that we describe these are sort of dark, almost look like purplish polyps. These are typically solitary. They don't have a high risk of malignant transformation, although it is there. We associate this with Peutz-Jeghers syndrome and juvenile polyposis. Okay, Peutz-Jeghers syndrome is a disorder, I'm sure you're familiar with this, where you get hamartomatous polyps throughout your whole body. And so typically the number one way it's going to be described is you're going to look at the patient's lips. And on the lips you're going to see a lot of dark, almost looks like freckles, purplish freckles on the lips. And these are essentially hamartomatous polyps of the lips. And so when you see a patient with these types of discolorations on the lips, and they have Peutz-Jeghers syndrome, they have these discolorations throughout the GI tract, from A to Z, from mouth to rectum. They're going to have these little discolorations, these little, essentially what they are blood vessels growing within the epithelium. Okay? So that's our hamartomatous. Adenomatous, now we're talking about cancer. We're making the transition here to start talking about neoplasia. So these are going to be neoplastic, can be due to the chromosomal instability pathway with mutations in APC and KRAS. Let's memorize those for sure. Adenomatous polyps with our APC mutation. Tubular histology has less malignant potential than villus. I'm not sure why there's a B here. Let's ignore that. So tubular histology has less malignant potential than villus. When you think villus histology, I want you to think of a villain, right, of the bad guy. And so the villain has the most malignant potential. If you have a mix of those two, tubulovillus has an intermediate malignant potential. Last, serrated polyps. These are pre-malignant. We consider this as it's going to progress to malignancy. This is due to the CpG hypermethylation, due to microsatellite instability. The genes involved here are MSH1 gene. And I don't know if you remember from when we didn't do it together, but when you discuss biochemistry and we talk about DNA synthesis and DNA repair enzymes, we'll talk about it together, but there's DNA repair enzymes that repair microsatellites. And so when these repair enzymes get mutated, it ends up leading to areas where you can have huge regions of DNA coding for the same thing over and over and over again, which are these microsatellites. And when you have the same thing coding over and over again, if that code says make more, do more mitosis, do more mitosis, do more mitosis, you're going to end up with cancer, right? Because you're going to have a cell that just grows uncontrollably. All right, so CpG hypermethylation with microsatellite instability, mutations in BRAF as well as MSH1. These are all things we need to keep in mind for what's going to be our HNPCC, right? This is going to be HNPCC. Sawtooth pattern of crypts on biopsy, and up to 20% of cases of sporadic colorectal carcinoma. Okay, so not associated with family. Screening for polyps is done by colonoscopy, right? So at age 50, you need to get a colonoscopy. If it's clear, you can come back in 10 years. If they see polyps, they may bring you back in 5. If you have a strong family history, they may bring you back in 3. Okay, they're actually pushing for these colonoscopies to be done even at 45, but the recommendation is still 50. But there may be a push by the time that you finish residency that we're screening people at 45 rather than 50 with colonoscopies. We also can test with fecal occult blood. Polyps are usually clinically silent, but because they can bleed, this fecal occult blood can be a good test. The goal is to remove any adenomatous polyps before progression to carcinoma. So adenomatous polyp is a dysplastic polyp, so it's a precursor for malignancy. When we talk about adenomatous polyps, again, we have these options. It can be a tubular adenoma, a villus adenoma, or tubulovillus, with villus adenoma being the worst prognosis and the most likelihood of progressing to cancer. So here we have a histoslide of a type of polyp, and you can see that I left the label off here. So why don't we just look at it together and see what we see. So as we look at this, we can see a lot of these look like the normal tissue that you see in the colon. Okay, so these would be representing all of the epithelium of the colonic lining. And so when we look on the inside of this polyp, we see the same thing. We see just a lot of normal colonic tissue. Okay, so in terms of saying what type this is, we should select a type that does not represent dysplasia, right? We don't see a lot of dysplastic cells. You can see some red blood vessels coming in here to supply the polyp. However, overall, this is a normal looking tissue, and so this one is going to be a normal polyp. Okay, this will be a normal polyp, one of our hyperplastic, non-neoplastic polyps that we talked about. Smaller, majority located in rectosigmoid area, relatively common. Okay, and why do we say that? Because we see a lot of normal colonic tissue. We don't see dark cells, and so this would just be a hyperplastic polyp. All right, now when we look at this biopsy, what we can see is that we have normal colonic tissue far on the right, and then as we move further to the left, we start to see dark cells. We start to see that the epithelium is not the normal light color. And we can see that it's starting to grow over the remainder of the tissue, okay? And so this is going to be our sessile adenoma. It's completely flat, and we see some neoplastic cells, these dark cells. Whenever you get a question like this on your exam, what you're going to see is that they will give you a little bit of the normal next to the abnormal, so that way you know to compare, right? If they just gave you a little bit of this sessile adenoma, say they only gave you a slide of, let me get my pen here, say the slide that they gave you was from here to here, it would be a lot harder to tell whether it's malignant or not. But being able to look at this normal tissue on this side and comparing it to this dark tissue here, we can say, okay, this looks like it may be some sort of neoplasia, it may be precancerous, and we're going to call this a sessile adenoma. It's flat, it's against the lining of the colon wall, so we call it sessile. Okay, so here we can see that there are these really long distended villi, very thin villi, very dark cells, and then we can see a villi here. This is going to be our villus adenoma, okay? And the way that you identify villus adenoma is just these very long, steep villi. In this slide, they didn't give you any normal tissue to compare it with. They should be doing that if you were to get it on a question. But the important thing to know with villus adenoma is this one has the highest risk of progression to cancer. In terms of our familial cancer syndromes, first we have our familial adenomatous polyposis. It's an autosomal dominant disorder, autosomal dominant, characterized by hundreds to thousands of adenomatous colonic polyps. If you look in this person's colonoscopy, you're just going to see tons and tons and tons of polyps lining the outside of, or the inside of the lumen. This is due to an inherited mutation on chromosome 5, and it increases that propensity to develop adenomatous polyps. Typically, we remove the colon and rectum prophylactically. We'll wait for these patients to sort of go through high school, kind of give them a normal life up to that point, because after you remove the colon and rectum, your patient may end up needing a colostomy bag, and it's really hard to sort of go through those teenage years with a colostomy bag. You know, in high school, it's not a fun thing. So, you know, out of concern for the patient's mental well-being, we will wait until after high school to remove that, but it will need to be removed before the patient gets older. Otherwise, they are going to develop carcinoma. Gardner syndrome is a subtype of FAP. Here we have some fibromatosis and osteomas, or growths inside of bone. Okay. So the fibromatosis is just a proliferation of fibroblasts in the retroperitoneum, and it will locally destroy tissue. So it's kind of hard to pick up. You really need to do a CT scan to be able to pick it up. So we will still see all those adenomatous polyps, but if your patient also has these fibromas, then you call it Gardner syndrome. Okay? Turcot syndrome, here it's another subtype of FAP, but these patients get CNS tumors, so medulloblastoma, glial tumors. That's something to look out for. Okay? But we will also still, again, see those colonic polyps. HNPCC, also known as your Lynch syndrome. This is our most common cause of hereditary colon cancer. These cancers are going to occur at a younger age, and most commonly right-sided cancers. Okay, and so we talked about this before, but we have an autosomal dominant mutation in the DNA mismatch repair enzymes MLH1, MSH2, MSH6, PMS2. Okay, so these are the names of several repair enzymes. There's about 30 different enzymes, but if you get questions, it's going to be on this MLH1, MSH2, MSH6. Look for that in the answer choices in finding your answer. Okay, so this is going to lead to microsatellite instability in the promoter and encoding regions, and you end up getting a rapid accumulation of somatic mutations that control tumor progression. Okay. And so here we'll see a Crohn's-like lymphocytic reaction with those crypt abscesses, mucinous sigma cell differentiation, medullary growth pattern. And these patients also have an increased risk of other cancers. So endometrial cancer in females, ovary cancer, You can see small bowel, stomach, urinary tract, brain. This is really an important point. So if you have a woman with colon cancer at age 50, what are you going to screen for next? Endometrial cancer, okay? This is a very, very important concept. Seeing colon cancer in someone that's so young should definitely raise a red flag and put us on high alert to look for other types of cancer, especially endometrial cancer, okay? So again, this is due to those mismatch repair enzymes. We do not see polyps here. This is non-polyposis colon cancer, all right? Great. Okay. So presentation-wise, what's the difference between right and left-sided colon cancers? Okay, so this is something that is really going to help you in terms of answering questions. So I'm just going to draw a colon really quick. I've drawn the colon so many times for you already that I should be a colon expert. So let's look at what our patient's going to look like if we have a right tumor versus a left-sided tumor. Okay? So let's start with our left-sided tumor. If we have a tumor growing here in our descending colon at the area of the sigmoid, this tumor, all tumors have a lot of blood vessels, and tumors tend to bleed. That's just true of any type of tumor in the body. Lung, stomach, any type of tumor is going to tend to bleed. So when your patient presents, they're going to say, "Doctor, recently I've been seeing a lot of blood in my stool." Okay, every time I use the bathroom, I use a little bit of toilet paper, I see a little bit of blood on the toilet paper. What's going on? So you, being the expert doctor that you are going to be suspecting colon cancer. You'll get the colonoscopy, and then you'll see this lesion growing and bleeding. Okay, so that is sort of your presentation of left-sided colon cancers. It's blood in the stool. Now, let's move over to the right. So say we have a tumor growing here, just above the cecum in the right side of the colon. So just like that left-sided tumor, it's going to bleed. But what's going to happen as that blood moves through the colon? It's going to become digested. It's going to change color, and ultimately, by the time this patient stools, the blood is not going to be appreciable at all. They're not going to realize they have blood in their stool. So this patient is going to go on la 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 la, living their life while they have this tumor growing in their colon. They do not see the blood. It's on the right side of the colon, and so that blood gets digested and they don't see it. What ends up happening is this tumor continues to grow and grow until stool cannot pass. Okay, and so these patients are going to tend to obstruct. These patients are going to present with, "Doctor, I haven't used the bathroom in about a week and a half. I haven't used the bathroom in about 3 weeks, and I feel like I'm really just stopped up. I cannot use the bathroom. What's going on?" You, being the astute doctor, you're going to do the colonoscopy. Well, you'll probably do a CT scan in that case. You'll do the CT scan, look for what's causing this, and you'll see that huge mass in that right side of the colon. Okay. Yes, this mass was bleeding, but our patient didn't realize it, so they didn't come to the doctor. Okay. So presentation-wise, what is the difference between right and left colon cancers? Right side obstructs, left side bleeds. That should be like a handy rule when you're approaching these questions in terms of knowing where the cancer is. All right, so getting into gallbladder pathology here, moving on from colon. Did you have any questions on colon before we move forward?
Sorry, can you repeat?
Oh no, I was just asking if you had any questions about colon cancer before we move forward.
No, I just was thinking why they taught me about the right and the left, and once they told me that because it's the right side is more liquid, it's not solid yet. That's the reason that you don't have much symptomatology, and because if you bleed, you don't realize because it's digested. So that's another reason why they grow, and it's too late sometimes when you find out that you have something in the right side.
That is an excellent, excellent point, Eva, and something that I actually forgot to mention here. So, Toby, if you didn't hear what Eva said, so essentially, as our stool moves through the colon, our stool is going to be more liquidy at this point, and then the colon's job, really the biggest job for the colon is to reabsorb water. Reabsorb water is the #1 job for the colon. So initially, as we have stool moving from the terminal ileum into the cecum, it's very liquidy, very watery, and as it moves through our colon, it's going to become more and more firm. By the time it reaches our rectum, it gets to that normal firmness. So if we have a cancer on this right side, the stool is going to be able to move through without becoming obstructed, right? And so, the obstruction has to become quite large before we prevent liquidy stool from passing by, okay? And so what he was saying is that can kind of contribute to the symptomatology, and what we see is that these patients wait a long time before they present because this tumor has to grow quite large before it starts blocking very liquidy stool. Okay, excellent point. Okay, great. So gallbladder pathology. The bile duct cells contain 2 enzymes that we see, ALK-Phos and GGT. Okay, so if we do a liver panel on our patients, if we check their liver panel, typically that means we're going to be checking liver enzymes, the transaminases of AST, ALT. We'll be checking their albumin level, their total protein level, their total bilirubin, direct bilirubin. We'll be checking their ALK-Phos and their GGT. Okay, all of those components are part of the liver panel. Okay, and so that would tell us if they have elevation in transaminases, which is our AST and ALT. That would tell us if there's been damage to the hepatocellular cells. If we see changes in your ALP, ALK-Phos, and GGT, that would tell us if there's damage to the bile duct cells. Bile duct cells. The cells lining the bile ducts have those 2 enzymes. Okay. Just as sort of a side note, elevations in ALK-Phos are also seen when you have elevated breakdown of bone. Okay, ALK-Phos is also seen when you have elevated breakdown of bone. However, when you have elevated breakdown of bone, you do not have an elevation in GGT. Okay, so when you see these 2 together, you say bile duct. When you see just ALK-Phos by itself, you say there's some sort of breakdown of bone going on. Think about your hyperparathyroidism, where you're breaking down bone. Think about your multiple myeloma, breaking down bone. Any of your bone cancers, breaking down bone. So in those conditions, you see elevations of ALK-Phos. But in gallbladder pathology, you see ALK-Phos and GGT. Okay, great. Let's keep it moving here. Oh, well, just kind of looking at our anatomy. We've been through it a few times here, but you can see in our liver we have tons and tons of these hepatic ducts. Here's a right hepatic duct, left hepatic duct, and that's going to drain all the bile via the common hepatic duct into the gallbladder via the cystic duct. When we have elevation of our CCK hormone, that's going to cause this gallbladder to constrict and eject all of the stored bile through the cystic duct, down through the common bile duct, down through the sphincter of Oddi, and into the duodenum. Okay? Great. Cholestasis is a fancy word to say gallstones. Okay? This is going to be precipitation of cholesterol or bilirubin in the bile inside of that gallbladder. Having precipitation of cholesterol or gallstones in here is going to be causing our problem. So there's sort of a couple different ways we can get this. If we have a supersaturation of cholesterol or bilirubin, if we increase the amount of cholesterol or bilirubin in our blood, that is in turn going to increase the amount of cholesterol and bilirubin in our gallbladder. Okay, that's how it works. The gallbladder is emptying all this stuff, and so it's going to end up accumulating there. That can lead to stones. If we decrease the amount of bile acids that we have, okay, say we take out the terminal ileum on our Crohn's patient, that's going to decrease the amount of recycling of bile acids, and we're going to have overall less bile acids to sort of emulsify and sort of dilute the amount of cholesterol and bilirubin in our gallbladder. That can lead to stones. or having stasis. When you have stasis here, if you have a patient that's, say, on total parenteral nutrition. Total parenteral nutrition is where we connect an IV line to our patient, and into that IV line we put nutritional fluid. If your patient is getting their nutrition via their veins, is their GI tract going to have any signal to increase CCK? No. CCK is stimulated by distension in the stomach, presence of protein in the duodenum. Things like this is going to increase our level of CCK. If we're getting all of our nutrition through our veins, we're never going to have any CCK elevation. Okay, CCK will never be elevated, so CCK cannot cause a contraction of the gallbladder, and so everything in the gallbladder is just going to kind of hang out there. And so in that stasis, we will have bacteria living in there that end up causing deconjugation of bilirubin. We're going to have all that cholesterol precipitating, and so stasis is a big, big problem in our patients that are, say, in the ICU, and they're on TPN for a long time. Okay? So I think I just kind of gave you a lot of information. With this very small bullet point, there's a lot of information here. Be comfortable with all of these ways to get gallstones. You can have a state of elevated cholesterol in your blood. Okay? Say you're a patient with hyperlipidemia. That leads to gallstones. You can have elevated bilirubin in your blood. Say a patient with sickle cell disease, where their red blood cells are being broken down at an elevated rate. You break down those red blood cells, that elevates your hemoglobin. Hemoglobin is going to be converted to bilirubin. Now you have a ton of bilirubin in that gallbladder. That's going to lead to stones. Okay. Decreased phospholipids and bile acids. Anything that decreases our bile acids can increase our risk of stones, because bile acids are in here emulsifying all that cholesterol and making sure that it's not too concentrated. And again, stasis, anything that prevents us from emptying our gallbladder at a regular pace, can lead to gallstones. So our most common type of gallstones are going to be these yellow cholesterol gallstones. These are radiolucent on x-ray, meaning you should not be seeing them on x-ray. This is important and will be described in questions. The typical mnemonic here, 40s, female, fertile, overweight, Crohn's disease with that decreased bile acid reabsorption, and increased estrogen leads to that gallbladder stasis. So this is the type of patient, and in your question stem, typically that's the type of patient that they will give you. Okay. Risk factors for our bilirubin gallstones. Here we have a calcium salt plus unconjugated bilirubin, unconjugated. These are radio-opaque. On an x-ray, we should be able to see them sticking out and looking at us. The risk factors for this type of gallstone is going to be extravascular hemolysis, meaning we have breakdown of our red blood cells. This is our red blood cell. It is getting broken down. Our hemoglobin is being released, and that hemoglobin is going to become bilirubin. Okay? Elevated bilirubin inside of that gallbladder is going to increase your risk of it becoming unconjugated and ultimately creating a gallstone. You can have an infection of your biliary tree in certain patients. There's also these sort of more rare conditions that I have seen come up in questions. So Ascaris lumbricoides is a roundworm that is going to infect the biliary tract and actually block that duct. Okay, Ascaris, typically when you have an infection with Ascaris, you end up with just a ton of worms. Okay. You end up with just a ball of worms. Rather than having one big worm, you just have a ton of worms. So those worms go all sorts of places in our GI tract, including the biliary tree. Our Clonorchis sinensis, here we have an infection of the biliary tract that's going to lead to cholangitis, cholangiocarcinoma, as well as sort of a fibrosis of that biliary tract. Okay. Great. What is our patient going to look like with gallstones? So you can get biliary pain, aka biliary colic. And in biliary colic, what's happening is you have a gallbladder with gallstones inside, and a nice amount of bile. And here's our gallbladder, here's our cystic duct. So our patient has a nice meal, the CCK gets elevated, CCK tells the gallbladder to contract, and now when the gallbladder contracts, this stone is going to get lodged right here at the neck of the gallbladder, considered the ampulla of the gallbladder. And now we have a bladder that's trying to contract against an obstruction. That causes pain, okay? Biliary tract, really the biliary, the gallbladder is trying to contract and trying to get the movement past the obstruction, okay? Cholangitis, this is an obstruction of the duct that's leading to inflammation. So in cholangitis, rather than having a obstruction here, in cholangitis, so here's our gallbladder, here's our cystic duct, here's our common hepatic duct, here's our common bile duct, and here's the lumen of the duodenum. Okay, there's our ampulla. So here we have a stone that moves out of the gallbladder. The stone actually is able to move down the biliary tree and obstruct a little bit further on. Okay, so this patient is not presenting with colic because the gallbladder is able to contract in this case. But what's going to end up happening is, because you have this obstruction, all the bacteria that's in this biliary tree, that's anaerobic bacteria, is going to be able to cause an infection. Okay, so with cholangitis, we have an ascending infection in the biliary tree. Okay, and that's due to an obstruction downstream. Cholecystitis, this is the most important one to know. This is an obstruction of our gallbladder causing an inflammation of the wall of the gallbladder. Okay, cholecystitis, just an inflammation of the gallbladder. And it's typically due to a gallstone being right there at the ampulla or at the neck. Okay, there's not necessarily a bacterial infection here. There can be. In about 50% of cases, there is a bacterial infection, but sometimes just this gallbladder that's been constricting against that stone so much for so often, it just kind of gets angry and irritated and inflamed, okay, and leads to your cholecystitis. No bacteria, but still an inflammation. Okay, and so, Eva, let me ask you, what is our treatment for cholecystitis? What should we do for this patient?
Well, I don't know.
Well, let me ask you this. Can our patients live without a gallbladder?
So yes, we can take it out.
Let's take it out, right? I agree with you 100%. They have a gallbladder full of these nasty stones, and some of those stones are actually obstructing the neck of the gallbladder. So rather than trying to come in here and break up the stones or spend about $1 million trying to, dissect the anatomy of the gallbladder, let's just take this bad boy out. Our patient can continue living on, and a lot of times they can even continue having a normal diet. Some surgeons encourage you to decrease the amount of fats, but if you don't have a gallbladder, you can't get any more gallstones. And so that is sort of one of the things we can keep an eye out for. We can just kind of take that gallbladder out. Take the gallbladder out. Obstructive jaundice. Here we have that obstruction downstream in the gallbladder, typically in the common bile duct. So here, because bile is not able to leave, everything in the bile is going to be elevated in the bloodstream. So what we're going to see is elevated conjugated bilirubin. Okay, our T-bili is going to be elevated, and our direct or conjugated bilirubin will be elevated as well. Okay. We'll also see elevated alk phos. Why? Because now that we have this obstruction downstream, all of these wall of the cystic duct is going to be inflamed with all that bile sort of sitting around and causing irritation. Okay. Because of a gallstone becoming lodged in the ampulla of Vater, we can end up getting some pancreatitis. So you can imagine, here's our pancreas here, sitting on the outside, and now that we have an obstruction, this is blocking the pancreatic ducts too. So now we have all of these digestive enzymes, our proteases, our tryptases, all of those digestive enzymes are just kind of hanging out here in the pancreatic duct, and they're going to end up causing a inflammation in the pancreas, pancreatitis. Okay? These patients should have jaundice. Gallstone ileus. So there's really one thing they're going to ask you about gallstone ileus. All right, so here's our gallbladder. Okay, here's our gallbladder, cystic duct, etc., etc. So the gallbladder physically sits about at the area of our transverse colon. Okay, when we think anatomy-wise and how all these organs are arranged nearby each other, the gallbladder is very close to this part of the transverse colon. okay? And so if we have a bunch of gallstones inside of this gallbladder, they can cause inflammation of this basal wall of the gallbladder, okay? So now we have an inflamed gallbladder sitting against the wall of the colon. So guess what? The colon's going to start feeling that a little bit. Now the colon wall is